And thank you for the opportunity to participate in this first of what I hope are many conferences. My disclosures, and I'll just take a moment here in case some of you don't know what the NBME is. I've spent much of my career working with the National Board of Medical Examiners based in Philadelphia. The NBME is a non-governmental, nonprofit organization celebrating this year 100 years of service to the health professions. We're best known as the developer and co-sponsor of the United States medical licensing exam, but we also provide many assessment services to support medical schools and graduate medical education programs around the world. We work with specialty boards, specialty societies, and other health professions to develop a self-assessment, certifying, licensing, and other kinds of exams, and are increasingly over the last decade sharing what we've learned over 100 years in the United States with colleagues around the world, now developing licensing exams in a number of countries to help agencies there. Examples include Panama and Singapore, working to support medical education, and developing and implementing the International Foundations of Medicine examination. Eric has provided a very nice overview of the notions of competency-based education, focusing on the individual learner and that individual learner's trajectory through an educational process. And today I'd like to focus on some of the needs. Several speakers have already referenced how important in a competency-based, individualized educational program having effective tools for assessment are. And there are three areas I'd like to touch on very briefly today around that domain of where the world of assessment needs to be going to support this disruptive innovation. Because if you stop to think for a moment, if the objective of a competency-based, individualized focus on education is for the individual learner to move through the development of specific competencies, perhaps as defined by milestones or entrustable professional activities, move through levels up to mastery, if that's the objective, and that each learner is expected to move in a different course at different pace, then we need to be able to understand that learner's progress, and the way we will measure or understand that learner's progress and be able to guide that progress is through information that assessment tools can provide us. So in this model, assessment becomes increasingly more important. Both Eric and John have mentioned that they believe we have a long ways to go before our assessment tools actually can live up to this challenge, and that's a bit of what I'd like to touch on this morning. So let me talk about each of these 3 points very briefly. I believe we need a deeper understanding of what it takes to make an effective clinician. We need a new focus on whether our theories produce better outcomes for patients, and we need new approaches to assessment as an integral part of learning. So let's look at each one of these very briefly. So what makes an effective clinician? And this, again, is not intended to be a comprehensive view, just a few thoughts as I prepared this series of observations. But I think thought it might be useful to contrast how we've approached some of these questions in the past and how we might in the future. So Brian Hodges, in a talk a few years ago, had a wonderful metaphor. He talked about medical education as the tea steeping model of creating a physician. That is, we put our student, the tea bag, into some hot water, and after some period of time, we think we have a suitable product. And a very nice metaphor, but it suggests that perhaps that's not the best way to create the most effective doctor. So historically, completion of a time-based course of study has been a focus, but in the future, in this disruptive approach to education, acquisition of all appropriate competencies necessary to providing effective patient care is really the focus and the endpoint. Completion of a defined time period of clinical experience is another hallmark of our current educational process. So many months or weeks of clerkship in each of certain disciplines, so many years of residency. But in the future, we'll need to focus not on the time in clinical engagement, but the kind of clinical engagement we have. We'll need to document graded increases in relevant clinical experience. In the past, we focused on the demonstration of domain-specific and global achievement of knowledge and skills. And in the future, we're going to need to focus appropriate growth, not just in minimum competency, but in mastery of milestones and EPAs. We've judged people based on their ranking or percentile performance on the assessments we present, but we're going to need to increasingly move from this normative approach to a much more criterion-based approach about how much is necessary to have achieved mastery in a certain competency or in a specific EPA. What are the criteria that define adequacy of performance to move to a next stage of education or development? And I think our historic systems, and I think Eric and John also have both alluded to this, have been that becoming a doctor has an endpoint, graduation, licensure, or certification. But I think in the new system, in the future, being a doctor is showing continuous improvement. So what do we need to manage to do some of these? And I can't, the time doesn't allow me to touch on each of the examples I just gave you, but let me touch on just a couple of them to give you an example of how we might hone in a little bit on what is required if we're to accomplish these shifts from the past to the future. So if we need to acquire all the competencies necessary to provide good patient care, how do we do that? What do we know about a framework of competency? What's necessary to take care of patients? Now, there are many competency definitions around the world. One of the things that really amazes me is that despite the development of competency frameworks independently by different groups of experts in different parts of the world, when you actually take the text of the competency documents and reorganize them according to one of them, I did this using the dominant competency structure in the US, the ACGME ABMS, 6 core competencies, there is nearly 100% match. Nearly every sentence of descriptive material, for example, in the AAMC Medical School Objectives Project or the CanMeds 2000 or the GMC Good Medical Practice can fit perfectly well within the framework of competency, and the same could be true no matter which competency framework one chose to work with. So this just looks at the remaining 3 competencies with that kind of parallel recognition. And this doesn't occur just at the top level of the descriptor, the label of the competency. It actually is true all the way down into the nitty-gritty details of the description. You find very similar statements coming from all these bodies all around the world. This tells me that we have a very strong consensus emerging about what it is that makes a good physician. But I think we need to be clear that having a theory may not be enough. Further elaboration of these competencies with milestones and EPAs makes sense, and Dr. Holmboe has mentioned this. But the point is not in the details of these competencies, but rather in the fact that we have a good starting place for competency-based education. But what is the challenge as we move ahead? Where do we need to go with this concept? These are terrific theories, and as I said, there's a very high level of international consensus, but until very recently, there's been very little empiric evidence that these are unique constructs. In fact, there's lots of evidence in the research literature that they're highly overlapping constructs. Now, this doesn't make much of a difference to have a common sense theoretical model that doesn't create completely unique categories, but until we learn more about this theory of competency that's outlined in these competency frameworks, until we understand more about what's unique and what is independent, we'll have some difficulty in designing efficient and effective educational and assessment systems. So, for example, to choose one illustration from assessment, if 2 competencies are highly interlinked, it doesn't make sense in an assessment model to require demonstration of some specified level of competency in that domain, in those 2 domains independently. One could do it, but it will be inefficient. Those will be highly intercorrelated. They'll predict one another, and there's not much reason to do it. On the other hand, if 2 different competency areas are not highly interrelated, then assuming competency in one because of demonstrated competency in another is not appropriate. It's not appropriate to average those scores. It's not appropriate to let competency in one domain substitute for demonstrated competency in another domain. So until we understand more about the structure of this theoretical framework of competencies, we'll have trouble building the kinds of assessment tools that are efficient and effective in answering the questions we need to answer about student progression through competencies, milestones, EPAs, and along the pathway to mastery. So looking at a second one of the examples, we need to document graded increases in relevant clinical experience, and this is an area of huge challenge. First of all, we need to know how much clinical experience in a specific domain area is necessary in order to achieve competence, at least for the average student. And then we might need to have some mechanism of understanding how students vary in the amount of exposure to specific kinds of clinical encounters in order to achieve the mastery that we desire. We actually need to do this through a new kind of data collection. I don't know how many of your educational institutions in this room are developing student portfolio systems. This is obviously something that's an essential part of individualized education. The NBME and Association of American Medical Colleges are working on releasing a system called PIVIO, which is designed to help gather and organize information about the educational course of each student. But things like documentation of clinical experience, what cases have I seen, how many of what kinds, become an important guide in determining the progress, the progression of an individualized educational process. And then think of the logistics. Looking at this makes me happy I'm nearing the end of my career, because I wouldn't want the job of trying to organize the clinical education process for a group of students who need to move at different paces through a large number of specified kinds of clinical experiences, and at the same time be delivering some level of service to the healthcare system, and to figure out how I schedule all that. How do I get those people in the right places at the right time with the right amount of workforce hours on the ward or in the clinic, and yet have each individual be optimally exposed to the right patients at the right time? A tremendously challenging logistical problem. So, looking at another one of the key parameters, do our theories produce better outcomes for patients? Something that, again, I believe we have not spent enough time historically looking at. In the past, we have felt that we could use proxies like credentialing status, licensure and certification, or accreditation status, largely process-driven, or perhaps records of disciplinary actions or medical malpractice lawsuits as indicators or proxies for whether the products of our education are actually producing better outcomes for patients. But it's pretty self-evident on the surface that these historical approaches to thinking about whether or not we are producing better outcomes for patients are not very, very powerful. In the future, we'll need to look much more at the outcomes profiles of individual clinicians. And so the notion of a portfolio of information is not just important during the clinical education or the fundamental education of a student, but carries on into a life of practice. It would be much more powerful and useful to understand the outcomes of a specific patient with that, of a physician with that physician's panel of patients, than to know whether he has a current license or whether she is board certified. It's not that I have any objection to licensure and certification, but they are distant proxies from the issue we really care about. And until we have systems that are capable of allowing us to make judgments about the performance of individual clinicians, this whole area of individualized, competency-based education and practice will be challenging. Furthermore, we might think of a system in which the quality of an educational institution is judged in some way by the aggregate quality of care provided, the aggregate measurable difference made in the health status of patients, of the graduates of that institution. If you were a dean of a medical school, wouldn't you like to be able to say that our school produces doctors who we can demonstrate have better outcomes than school X down the road? No, none of you would like to be able to say that. But that's really what we care about, isn't it? It's being able to show the impact of what we do. So we've been doing a lot of work at the National Board in implementing ideas, concepts from the Lean and Six Sigma quality improvement models in our work. And this is a tool from the toolbox of those quality improvement methods that has helped me really grasp, I think, a key point. We set out with strategies of what we want to achieve as an organization. And when we're talking here today, our strategy is to improve the health of the populations we serve. And then we use our best creativity to think of solutions of how are we going to make that happen. And what we're talking about in this particular disruptive innovation session is individualized competency-based education. Where we fall astray is we often measure our success by how well we implemented the solution, not by how well we changed the strategy. We might have measures of how many competencies did we teach effectively? How well did our students score on assessments related to mastery of competencies? And those are all worthy and good parts of the process, but what we really care about is how much did we change the health of the population? And we're far, far from having very good tools to do that. But let me distort Dr. Norsini's work through a tremendous oversimplification. This is based on data published last October in Academic Medicine by Norsini and his colleagues, which looked at performance on the USMLE Step 2 CK exam. The exam is explicitly designed to assess the knowledge and application of knowledge related to patient management skills. And it looked at a cohort of international graduates and the outcomes of the patients of those graduates in coronary artery disease, looking particularly at mortality. And what the study showed is that there is, in fact, a relationship between the score on Step 2 CK and the mortality rates of patients of the doctors who got those scores. And in fact, this is, again, a very crude extrapolation of John's work, but it basically showed that about 20 score points on the score scale meant that the patient would have a 4% lower mortality rate. So someone who got a group of examinees with 220 scores would likely have patients with 4% lower cardiovascular mortality than a group of patients of doctors with 200. Now, I'm not suggesting causality in this analysis, but I think it is the kind of evidence we need to begin to gather. If we have a curricular design or a duration of education, one of the things we want to know is, do the doctors who are subject to that innovation have patients who do differently from the doctors who weren't? Or if we have a measure of accomplishing milestones, do the doctors who accomplish those milestones have any different outcome from patients than those who don't? This is the ultimate evidence that our theories, our solutions are right, and these measures of what we wanted to change are really critical. So finally, let me close with just a couple reflections on specific challenges for assessment of this arena of competency-based education focused on individual progress. So first, in the past, assessment has often been an afterthought. Eric mentioned his belief that curriculum and assessment design need to be integrated, and I couldn't agree more. I think in the current models, we often design a curriculum and say, how shall we assess it, instead of working both through together. Because in this model of competency-based individualized education, assessment is key to the design. We have few modalities focusing mostly on knowledge, and we have to shift to a model of many modalities focusing on all the competencies, milestones, and EPAs that we care about. Most of our assessment traditionally has taken place outside the workplace context, and in the future, most of our assessment needs to take place embedded in the workflow, where there is clear evidence of the relationship of the assessment to the outcome objectives. We've focused on high-quality, high-stakes exams, but not paid much attention to low-stakes formative exams. And if in our new systems, those lower-stakes continuous assessment processes are used to steer learning, to make decisions about progression, they have to be high quality. We can no longer say, oh, it's just formative, we don't care whether it's reliable or whether there's any validity evidence. We have to shift our focus from very high quality, high stakes exams to very high quality assessment tools that support the learning process. We have well-developed statistical models, classical and IRT statistical models, to support traditional assessment formats. Unfortunately, we don't have nearly as well-developed statistical models to look at things like how do you disaggregate the performance of individuals within teams to understand both individual contribution to teamness as well as the whole is greater than sum of the parts component of that particular team working together. Statistical tools to look at that are simply not available. And similarly, if we want to know something about how do we combine longitudinal information, scores on different kinds of assessment across time, to understand whether that student is really progressing across a continuum toward mastery, we don't have very good statistical tools now that allow us to make combinations of those observations over time that give us meaningful inferences. And finally, we've often focused on highly structured examinations and not spent much attention on what's required to make good observational assessment. Clearly, if I think back on days when I filled out clerkship rating forms, there wasn't much structure, there wasn't any training, and we know from the research that the results didn't mean much. The assessments drawn on those workplace-based observations were largely meaningless. And the research also makes it clear that we really need to focus on becoming better raters as clinicians. We need to rate one another, we need to rate our students, we need to be rated, and to do that we need to know something about how to do good rating. So finally, if all these things were available, the geographic location or credentials of the educational institutions contributing to training, the amount of time spent in training, and the approaches used to achieve mastery should be irrelevant in decisions to license or employ health professionals. I threw this slide in at the end because I think it demonstrates how disruptive this approach to learning and assessment might be. Thank you.